today we will be talking about decompensated cirrhosis, and specifically how to present a decompensated cirrhotic on rounds. We have a system called VIBES, VIBES, that we use at our hospital, which I actually think has been pretty good for organizing everything. So you start with the volume, right? So this is any type of edema, so specifically ascites, right? So you mention, okay, do they have ascites? Do they have lower extremity edema? Do they have hepatic hydrothorax, right? And just generally, I'll be starting with the diagnostics, and then I'll be moving on to the treatment for each of the letters. So for that, you want to be talking about what your target diuretic goal is, right? So target net negative, 1 to 2 liters is usually what we say, more or less depending on their physical exam findings. And then the very important thing for all cirrhotics is to have a 5:2 ratio of spironolactone to Lasix. And that is just standardized for cirrhotic patients. I think it also helps balance out their K. And then you also want to be talking about their diet. So all cirrhotics should be on a sodium restriction, right? And then for hyponatremic patients, specifically less than 125, you want them on a fluid restriction. Okay. So that is volume. So you talk about the physical exam findings, net negative, etc., and then your diuretics. Next, we will go to infection. Okay, infection. So in cirrhotic patients, the big one, of course, with ascites is spontaneous bacterial peritonitis. And that should already be diagnosed on a diag para that you got when they initially came in. Now, what an active SBP infection looks like is if the PMNs on the tap are greater than 250. I've also seen it, maybe the PMNs are less than 250, but you actually grow bacteria in the culture, that also counts. So the first thing you should do is DC any type of beta blockers that they're on, right? And then, you obviously treat the infection, but sometimes you talk about primary prophylaxis for SBP, or secondary prophylaxis, meaning have they already had SBP before, or have they never had it, but we're just placing them on prophylaxis antibiotics. And so that is normally ciprofloxacin, 500 milligrams. Sometimes doctors or hepatologists use Bactrim. Okay, so treat the SBP and then talk about any prophylaxis if there isn't an active infection. Now we can talk about bleeding, right? So you can talk about if they've had past variceal bleeds or any coagulopathy that they have. I really butchered that word there, coagulopathy. And then of course, for treatment, you want a beta blocker, specifically one that is non-selective. And then, if they're having, or there's a concern for an upper GI bleed, that's when you want to be doing the PPIs or octreotide, right? Okay. So that is B, bleeding. You talk about any past bleeding, variceals, or any coagulopathy that they have. And then if they have an upper GI bleed, PPI or octreotide. Next is encephalopathy, right? So this will happen in a lot of patients who have liver disease, right? And so we don't know. No one checks ammonia at my hospital, and I think all the data supports that. You really are just going off of the physical exam. So explain, how they're altered, whether they have asterixis, anything like that. And then you want to give goal bowel movements, usually 2 to 3 times a day for lactulose. And then you just up-titrate the lactulose dose to get to those bowel movements. And then, of course, there's rifaximin, right? So whether they're on rifaximin or not. And then the last one is pretty easy if you're an intern. It's just screening. Okay, so if they are pre-transplant, right? Screening slash surgery. If they're pre-transplant, the liver doctor should really be telling you, what they need. So you can say pre-transplant workup, right? And if they're post-transplant, this is where you add like their tacro or any other meds that they're on, as well as their goal. Okay, and that's it. VIBES.